in Fort Worth. It is a community and teaching hospital. We do have residents as well as medical students retained in our clinic. And and UNT, University of North Texas, Texas College of Osteopathic. I have a degree in occupational therapy, and I also finished a master's in medical sciences at University of North Texas, where I'm currently affiliated with. I finished my doctor of osteopathy in 2014. I spent 4 years in Kansas City, Kansas, at the University of Kansas for my adult neurology training. I did a year fellowship for oncology, neuro-oncology at UT Southwestern Dallas, and stayed in the area in John Peter Smith in Fort Worth, right across town. So neuro-oncology is a very subspecialized field. So people may ask what made me choose occupational therapy. So I think that stems a lot from, and of course you can ask me later after my lecture, but it stems a lot from my background as an occupational therapist. I am a non-traditional student. I had a career for 10 years in occupational therapy before I became a doctor. And I worked as a rehab therapist for a year and a half at MD Anderson Cancer Center on the rehab floor. And I specifically was doing the rehab of post-craniotomy patients. And I see a lot of glioblastoma and primary brain cancer. And I think that was the motivation for me to go into neuro-oncology. I also did electives when I was a medical student with Dr. Edward Pan, who is the UT Southwestern program director, and that's how I ended up doing my fellowship there. And I was very interested in neuro-oncology. I made sure that every step of the way in my residency training, every time there's an elective, I would choose somewhat as a rotation that could benefit me to become a neuro-oncologist in the future. So what do neuro-oncologists treat or see? So we essentially treat primary brain tumors. When I say primary brain tumors, the tumors come from the brain itself. The most common, interestingly enough, the most common tumors in the brain is not primary brain tumors. It is metastases, which is most everyone are familiar with. If you have a breast cancer, lung cancer, once they reach the brain or any part of the body, then that becomes a stage 4, a terminal cancer. And so those are the most common part. I see them as well, but with regarding giving chemotherapy and targeted therapy, immunotherapy, I primarily deal with primary brain cancers. We're talking about glioblastoma, astrocytoma, oligos. I'm going to give you a brief introduction to them down the line, as well as pictures for you to visualize what they look like. More uncommon cancers, ependymomas, vestibular schwannomas, pituitary adenomas, I also see. Meningiomas are very common cancer, not very aggressive, but I also see them as well as leptomeningeal metastases. And I'm going to explain that later and show you a picture for you to visualize what that is, what those are. And I also see a lot of neurological complications of systemic cancers. So what does it mean? If you have a brain tumor from primary brain cancer, that is a space occupying lesion. And so if that puts pressure on your brain, you would have seizures, you would have headaches, you would have weakness, numbness. It depends really on where the tumor is pressing on. And you'll have confusion. So a neuro-oncologist will also deal with these neurological complications or sequelae of systemic cancers. So how common are primary brain cancer? And so they're only comprised of 1.3% of all cancers diagnosed in the US. And they are categorized according to their cell of origin. And so if you think about the cells in the central nervous system, there's neurons, which are your brain cells. And there's also the cells of the brain, which is the matrix. So you've heard me mention of gliomas, because this is basically the bread and butter of every neuro-oncologist. What are gliomas? These are the common type of brain tumor. Like I said, they're categorized based on which cells they arise from. Oligodendrogliomas are basically the cells that put in myelin on the dendrites to make the conduction of the nerves faster, and they usually are egg-shaped appearance on histology, and so they could be grade 2 or grade 3. Oligodendrogliomas never go
You
into
see,
grade 4.
Dr. Mantilla, we don't see you presenting anything on the screen. Do you want to try again to share your screen? Because
Sure.
I
Was I
don't think
presenting? Was I presenting? Were you able to see something earlier, or you never saw anything
No,
at
yeah,
all?
we haven't been able to see anything throughout the
Oh, I'm
presentation.
so thank you for pointing that to me.
Yeah,
I'm sorry. I'm so
no
sorry.
worries.
I was just like, okay, I'm so sorry
No,
about
because I
that. Let
realized
me
you're
go
looking at your screen, but we don't see anything. So,
out. Do you guys want me to go back or just keep
you can
going?
just start presenting from wherever you are. See if you can share your screen again. Oh yeah, it's working now.
Okay. All right. I apologize about that. I missed a step.
It's okay. All
All
right.
right. Okay. All right. So that's better now? Okay. Okay. So like I said, gliomas. So gliomas are the bread and butter of neuro-oncologists because we mainly treat primary brain tumors, and that means that the tumor comes from the brain itself and not somewhere else. So there are three types that I see very commonly in my clinic. So there's oligodendrogliomas, which arise from cells that make the myelin sheath on the nerves or the dendrites, which are part of the nerves, make them conduct electricity or impulses faster, and they're not very aggressive. So I tell my patients this: if there is a lottery for brain tumors, if you get an oligodendroglioma, then you won the lottery because it's not very aggressive. Even if you have grade 3, the longevity is still about 8 to 10 years, sometimes more than that. Not sometimes, commonly more than that. And so, and they do not go to grade 4. So these are. Next is astrocytoma. Matrix of what the brain is composed of. And if the tumor arises from an astrocyte, they're called astrocytoma. Now, grade 2 and grade 3 are, are lower grades. And I will tell you down the line how can you identify them radiographically when they become grade 3s. Now, grade 4 astrocytoma is the most aggressive, but we don't call them grade 4 astrocytoma. They become glioblastoma. Okay, at that point. So if an astrocytoma becomes very aggressive, more than a grade 3, then it is termed a glioblastoma, which is grade 4, the most aggressive brain cancer that I treat all the time. And we still don't have the treatment for it. So just showing you pictures. So the top, let me see, can you see the arrow? Okay, this is a picture of an oligodendroglioma. This is an MRI. There is a lot of sequences on the MRI that unfortunately we don't have time to go over, but I would love to go over them with you if you want to learn about it and reach out to me. I would love to teach you about it. But basically, these are not very aggressive tumors. They're slow growing, and most oligodendroglioma presents with seizures because they are slow. They're slow growing. This does not enhance on MRI. So this is just basically a swelling in there, which do not have a contrast enhancement. This is an example of an astrocytoma grade 2. It doesn't look very different from oligodendroglioma, but if you pull up a contrast enhancing lesion, that means that when you get an MRI, you inject the person with contrast. If there's a leak in the dye around that area, that means that that tumor is becoming very aggressive because it is outgrowing its blood supply. So it's forming its own blood supply, and the blood supply that they form are leaky. That's why the contrast that you inject on that person leaks out. So if you have an enhancement, that then is your radiographic indication that 2 weeks of headaches, never had headaches in the past. And also, He's also had some he's been bumping on the on things on the left side. Sorry, weakness on the right side and bumping on the left side. And so what I think I should have, we should be the next slide. So this is the MRI. As you can see, a butterfly enhancing lesion. This is a contrast MRI on the right side. So this is the lesion. It probably was pushing into the motor cortex on the right. That's why the patient has a left-sided weakness. And also look at this lesion over here. So this is a multifocal GBM. The lesion over here is close to your occipital area where your vision is. So that's why he was bumping on the on the left side. If it's the brain, always on the opposite side. The symptoms are on the opposite side. So what does a patient have? He's got GBM. He had resection, he had surgery, and then that's where we get the pathology. The patient has GBM. So again, GBM is very aggressive, 23% of all CNS tumors and 65% of all malignant gliomas. And the mean age is 62 years old. So our patient was 60, so right about that time. And the most frequent sites are the temporal and the frontal lobes. Males are more, the male predominance is a little higher, 1:5. And what are the causes of GBM? So I've been asking my patients this: is it cell phone use? Is it radiation? You know, is it genetics? So the simple answer is we don't know. There may be some genetic component in some cases, because there are, in 5% it is associated with familial brain tumor syndromes. Like if you have Romania, you just don't have brain cancer. You have cancer in the GI. You have cancer somewhere else. So 5% of GBMs are like that. We also see GBMs a lot when they have been radiated as a child. We also see that a lot, and so for benign meningiomas. But the true answer is we don't know what caused this. So this is just a description of how it looks like. You already looked at it. It is bright on that contrast because it's leaking contrast, and it has a dark necrotic center. It also looks like METs. METs could also look like this, and CNS lymphoma could also look like this. Infection, brain infection can also look like this. So that's what we need to get tissue, because we just don't diagnose radiographically. We have to get pathology to make sure it's GBM and it's not an infection or it's not another type of cancer. So like I said, this is the enhancement. This is the leaking of the dye, and look at the tissue. It's dark. That's dead tissue right there in the middle. Okay, and so the histologic hallmark of GBM are there's necrosis or dead tissue, and there's microvascular proliferation, or they make their own blood vessels, like I said, to feed themselves, because they're growing so fast they outgrow their blood supply. So they make their own blood supply, and these blood supplies are very fragile, very leaky. That's why when you inject dye into them, they leak dye. So this is what a GBM looks like. Can you still see my slides? Okay, so this is what a GBM looks like in gross anatomy. So look at the necrotic center. Look at the dark necrotic center. Look at the red, bright red. They're basically very vascular, a lot of blood vessels in there. They make their own blood vessels because they have outrun their own blood supply. And look, typical butterfly glioma, that means that it extends towards the opposite. It passes through the corpus callosum, or the structure that connects both hemispheres of the brain. And so this is a histology slide, very interesting, of a GBM for 12 cycle, for basically 12 cycles. And one cycle is five treatments of chemotherapy, orally, and 5 out of 1 month, and then you do that for 12 cycles, and then we do MRIs every 2 months.
Tito, so I think it's stop sharing the presentation.
It's not sharing again? Okay.
Yeah.
Okay, so I'll try to share it again, but you were able to see it earlier, right?
Yeah.
Yeah, we were able to see it earlier.
All right, so let me share it again. I'm so sorry about that. Okay. Do you see it now?
Yeah, it's working.
Okay, all right. All right, so like I said, the standard of care is radiation. During the radiation, it's 6 weeks of radiation. We give them temozolomide. That's the chemotherapy. It's oral. What is temozolomide? Briefly, it is an alkylating agent. So basically what it does is, as the cancer cells build DNA, that temodar throws in a methyl group in there. Just I think of it, the methyl group as a wrench. So it blocks it, and so it enhances the radiation. So while they're doing the radiation for 6 weeks, they take temozolomide. That's the chemotherapy that I'm giving them. And the part 2 of the treatment is just temodar, no more radiation, and it's 12 cycles of taking temodar just 5 days out of 1 month. So that's 1 cycle, and then we do 12 cycles of that. And after that, we do follow up every 2 months. Unfortunately, a lot of my patients progress while during the treatment. I would say about 30–40%. Half of them complete the 12, and then it's not a question of will it come back, it's a question of when it will come back. So I always brace myself for the time when it comes, and after that, we give them other chemotherapy. There's not a whole lot. There's a choice of 3, and that's the reason why we have a lot of clinical trials, because we're still finding the standard of care for recurrent GBM and better overall survival for the newly diagnosed GBM, better than what we're giving right now, the radiation and the temodar. So what are the current trends? What are we doing in clinical trials right now? These are currently under phase 1 and phase 2. Only a few are under phase 3. We do immunotherapy, and it's not just in brain cancer, but in all types of brain cancer, immunotherapy. So just to give you a brief overview and explanation of what immunotherapy is, we basically use our own immune system to kill the cancer cells. So cancer cells are very tricky, not just brain cancer, but cancer cells in general. Let me point you to this slide right here. It has a PD-1. This T cell, that's your immune cell, is a PD-1 programmed cell death death receptor, and a PD-L1. The L is for ligand, or programmed cell death ligand. Now, what happens is the cancer cell blocks this interaction. So when it blocks the interaction of the PD-1 and PD-L1, your T cell, which naturally would kill anything foreign in your body, including cancer cells, could not do its job anymore. So basically, what the cancer cell's doing is it's stopping your ability for your immune cells to kill the cancer itself. So what does this we call these checkpoint inhibitors, a part of immunotherapy. What does checkpoint inhibitors do? They stop that, they remove that, they make sure that the T cell docks with PD-L1 so that the T cells can kill the cancer. That's what it does. And what else are currently going on right now? There's vaccines. So what happens with a vaccine is lab scientists would deactivate a cancer cell, get their peptides, get their proteins, and then make a vaccine out of that and inject that directly into the cancer, into the brain cancer. And then your body will mount an immune response towards that inactivated peptide, just like when you're getting vaccine for a flu. So those are still being studied. And there's also a device called Optune. I think I picked the wrong picture because he's actually wearing something to cover it. But Optune is a device that they put in their head to basically generate a low voltage electricity. So what happens when cells divide? That's how you produce cells, right? They divide, they pull away from each other. During telophase. So when they pull away from each other, what the Optune does, it generates a low voltage electricity to disrupt that natural electric repulsion of cells away from each other. And so when they cannot divide into two daughter cells, they do go apoptosis. They undergo apoptosis, or they kill themselves. So this actually is FDA approved for GBM already. So I recommend this to a lot of my patients. The Optune device. So what are the pathways to neuro-oncology? If you are not yet bored and you're probably interested in neuro-oncology in the future. And so you can either go through the internal medicine route or through the neurology route. If you go through the internal medicine route, you do 3 years of internal medicine after medical school. Then you do hemo. That's another 3 years. And then you do 1 or 2 years of neuro-oncology, depending on where you do your neuro-oncology fellowships at. It is 2 years mostly in the bigger centers such as MD Anderson and you know, identify Farber. But I did a 1 year at UT Southwestern for clinical neuro-oncology. There is an optional 1 year for a lab. Basically, for an entire year, you'll be sitting in labs putting GBMs in mice, and I opted out of that because I want to be more on the clinical side. And then after doing neurology for 4 years, then you do a fellowship in neuro-oncology. So these are the pathways to become a neuro-oncologist. So what to do when, you know, after medical school, you really wanted to become a neuro-oncologist. So I would suggest doing these rotations as early as your PGY2. You can do a neuro-oncology clinic at your hospital, neuropathology, so you can look at slides early, then you're able to do some research on it, partner with some a physician or an attending that you'd like to maybe write a case report with or do research with. And so by the time you apply for residency, you know, you have a publication on your resume, and that really will help you with your interviews for your residency. For instance, I was able to not publish, but present in a poster as a medical student, a very interesting case in neurology. And during my interview, that was all we talked about. And my interviewer would say, you know a whole lot of this than my residents. And so for me, that was a good thing, because, you know, you basically left an impression. And so for me, you know, if identifying your interest early is key. And this is just an example of intrathecal chemotherapy. Remember I told you about that leptomeningeal enhancement, where if it's stage 4 cancer already, the cancer has spread not just to the brain, not just to the liver, to the lungs, but also it has spread on the meninges, which is the structure surrounding your brain. At that point, their lifespan is between 3 months to 6 months. And so what do you do? We don't have a standard of care. That's the answer. But there are some case series or case reports where you do intrathecal chemotherapy. What's intrathecal chemotherapy? You basically directly inject chemotherapy into their brain. And then when you do that, that could prolong their life for a few months. You know, the question is that few months worth, if you have the side effects of having chemotherapy directed into the brain? What are the potential side effects? Headaches, seizures. I have a patient who I did this on who had a seizure. So imagine you trying to inject on a brain, and then once you're injecting chemotherapy, the patient had a seizure. So, you know, the answer is there's no standard of care once you have the leptomeningeal enhancement. And so it's at that point, if there's bulky disease, that means that there's a lot of disease going on. If the patient is in good shape and the patient is willing to try because they want that 3-6 months possible survival benefit, then by all means, I'll give it to them. But under the caveat that I would not assure them that, you know, that it's going to be a quality of life. There's not going to be any headaches. There's not going to be seizures. I can't even assure that it's going to be an extra 3 to 6 months. And so, you know, and that's where the science of medicine comes in, because you have to talk to the patient and you have to make a plan with them, you know, collaborate with them. And you don't learn that in medical school. So that's where the science of medicine comes in. Oh, no, I'm sorry, not the science, the art of medicine comes in. So, yep. Interest in oncology, identify your interest early. Persistence, you have to, you know, it's okay to try again, you know. So what stage are you in right now? You guys are undergrads, so you guys may be taking MCATs, so you guys may be taking your undergrad. And a lot of times in medical school, I have classmates who did the non-traditional route. They delayed a year or two to get a master's degree to get their GPAs up. But then did that stop them from going to medical school? No, it took them 2 or 3 more years, and then, you know, after that, they're now physicians just like I am. For me, talking about persistence, I did not go to medical school on first try. I was an international medical student when I came here, and so nobody would recognize what Velas College from the Philippines sees. And so every time I apply, I wouldn't get an interview, and then that's when I decided to do the master's program, and that kind of helped me. So it took me a lot. It took me about 3 to 4 years before I finally got into medical school, but here I am now. And so persistence is key. If you have a subject that you need to, that you're, you know, having a hard time on, and you want to raise your GPA, it's okay. It's okay. I have that issue as well. My classmates have that. You know, if you have a low MCAT score when you first took it, it's okay. I took it 3 times. It's fine. You know, a lot of people took it 1 time. Good for them. I took it 3 times. It's fine. And then persistence is the key. At the end of the day, it's a marathon. It's not a sprint. You know, be resilient, know the goal, jog towards a goal, and don't sprint, because it's a long road. It's a long road. So I think that concludes my lecture, and these are my references. I think we're now open for questions. Maybe I can stop share.
You guys can feel free to unmute your mics. You can turn on your cameras as well, and we'll definitely be around until whatever questions you have to ask, y'all can do.
I actually have one.
Sure.
All right, Dr. Mantilla, thank you so much for coming here. At least for me, like what I'm trying to at least like figure out is your mindset with going into this specific specialty.
Right.
At least like, you know, as a physician, like, you know, or at least like, you know, growing up, the idea of a physician was primarily to just like, you know, be able to, it's like, you know, cure patients, like really be able to help them out. However, with this field, like, you know, still, I guess like, you know, being in development, you know, there's still a lot that you don't necessarily know. Like, how do I guess you deal with the idea of you not necessarily being able to like cure everyone, and that like, you know, you can only, I guess like, you know, I guess like help them, I guess like in their final days instead of like necessarily like, you know, being able to.
That is a very good question. And you know what? You're not the first question, you're not the first one to ask me that question. My classmates asked me that question in medical school. It's like, why neuro-oncology? That's such a depressing field, you know, but these patients also need somebody to take care of them. So and so that's how I looked at it. And so if an untreated GBM, let's say you had surgery and you didn't give him chemotherapy, that's less than 6 months. So imagine with our current treatment for glioblastoma, you give them the radiation, you give them the chemotherapy, you can give them 12 to 15 months. That's twice the month that they can spend with their family. And not only that, you know, let's say I can't cure them, you know, but for the time being that they were diagnosed with a GBM, let's say, you know, let's say we don't give them chemotherapy. Let's just say they never had surgery. They get diagnosed, they die 3 to 6 months. What are the possible complications during 3 to 6 months? You're talking about severe headaches, pain management. You're talking about seizures. You're talking about, you know, weakness, paralysis. So that's something that as a neurologist, as a neuro-oncologist, you can give seizure medications for, and you can control that. You know, that's palliative. Palliative means that you try to make their last days as comfortable as can. And for me, that's very therapeutic, not just for the family, not just for the patient, but for the family as well. Imagine how traumatic is it for the family to look at their loved one for 3 months wasting away but having seizures every day. And so I think of it that as a neuro-oncologist, if I don't get to treat their cancer, I can hold it off, and I can't treat it completely. At least I treated their seizures. At least when their brain was swelling and they had severe headaches, I gave them steroids and their headaches had improved. And that quality of life for me is worth it.
Thank you so much.
You're welcome.
Dr. Mantilla, we have some questions in the chat. I'm just going to read them to you.
Sure.
What advice do you have for students who are hesitant about pursuing the DO route as opposed to the MD route? Is our first question. So
I guess I'm going to throw the question back. What is the hesitancy about? I'm not sure if you would have a direct feedback because that's the chat, but I am just going to assume a lot of the hesitancy probably would be that still stigma, right, about the DOs rather than MDs. I think that's pretty much what everybody is concerned about. But let me tell you that aside from that, there's a whole lot of DO residencies there by itself. I didn't go through a DO residency. I went through an allopathic school or an MD residency. So I took both the I forgot the USMLE and the COMLEX. The COMLEX is the licensure for DOs. The USMLE is licensure for the MDs. That as DOs we can take both. So I took both for me to be able to go through the allopathic residency. I took both. I take that back. You don't have to take both to go into an allopathic residency. I took it back. It's just for me to be more competitive, and so I took both. And so for me, my answer to that is the people who had the stigma of DOs versus MDs are getting older and are retiring. Okay, I went to University of Kansas, and the plastic surgeons are DOs, but University of Kansas is an MD school, MD resident. I mean, it's an allopathic program. A lot of the surgeons are DOs, and so a competitive subspecialty. And so that for me is a progressive hospital, and they were able to. For me, the barrier of a DO and MD are broken because essentially there's no difference. You know, there's two paths to being a doctor in the US, allopathic route and osteopathic route. And you can be whatever you want as a DO, just like the MDs. So that for me, that misconception is slowly, over time, is slowly being broken because people who have that limited thinking are retiring, and right now we're just more progressive thinkers. And so I did not experience that as a resident because I was in a program where the competitive specialties are filled with DOs is equal and respected as equally as MDs. What you can probably do though, when you apply for residency, is because when programs look at you, let's say you apply to an allopathic program and then you only took the COMLEX, it's hard to compare apples to apples. And that's the reason why I took the USMLE, because I know I will be competing with MDs, so they would have the USMLEs. I want to be able to have a score that they can compare apples to apples with. Okay, but that's just not what they look at. They look at your GPA. They look at your letters of recommendation. They look at your interview skills. And so, but at the end of the day, I want to make sure that I'm being compared equally to my MD colleagues because, so that's what it is. So my recommendation is, if you want to be sure, then take both. Take USMLE and COMLEX. You don't have to, and that's what I did. Mm-hmm.
Our next question is, what are your opinions about doing a post-bac program versus a master's program? And also, do you think students should take their MCATs before they consider doing these post-undergrad programs?
Okay, and so when you say master's program, I guess I'm confused. I think it's terminology. So I'm guessing post-bac programs don't give you a master's degree, correct? And a master's program gives you a master's degree, but they would still give you the edge, maybe an opportunity to increase your GPA and increase your. Is that correct?
Yeah.
Okay.
Yeah, that's correct.
Okay. So I really don't think there is a difference. The reason why these programs exist is to increase, to make you more competitive for medical school. Let's say you came in with a GPA of, like a 3.5, and you go through a post-bac, and then you're still up 3.7, so that's good. And then I think the same thing for a master's degree, like I actually did that. I'm not sure if everybody knew that. So the master's degree that I posted was a master's degree in medical sciences, which is linked to the medicine program at UNT. So basically what we were told when I was a student was it was a trial for medical school. All our subjects were first year medical school subjects. We have the same teacher, we have the same PowerPoint as the medical students. And so if you do well on it, then it's good for you because you've proven to them that you're going to be a good medical student, and so that's going to be you're going to be a shoe-in for them. And if you did bad on it, so basically you're basically sealing your fate because you basically just told them that you can't handle the rigors of first year medical school if you fail the master's medical program. So my answer to the question, long intro, is I don't think it makes a difference. I think doing a post-bac or medical science gives the program or the medical school an idea that you really wanted it bad. You are trying to improve your application by doing this. And I think that's really good on the application if you do that. I don't think, in my personal opinion, I don't think it matters which. I think it matters if you take them, not which one specifically. And I think it would really help you, just like it helped me. But know that it could also be a double-edged sword, because if you fail or don't do good at it, then you basically sealed your fate.
Okay. Our next question is, how does healthcare policies and insurance companies affect you as a neuro-oncologist compared to other general physicians?
That is a very good question. I am very fortunate to be on a county hospital, a community hospital. So a lot of my patients are indigent. They don't have insurance. They don't have commercial insurance. So they have what we call JPS. That's the name of my hospital, John Peter Smith, JPS connection. So if you have JPS connection, what we do is for my chemotherapy, because they don't have money or insurance to pay for it, we apply for pharmaceutical help. So we have what we call a patient assistance program, or PAP, to fill out, and then the pharmaceutical company would say, okay, they really don't have money to pay, they don't have insurance. Okay, we can give the drug for free. So I may be the outlier for the neuro-oncologist, but I was a UT Southwestern where commercial insurance was the norm. Paying for chemotherapy is not hard. I take it back. What's your definition of hard? So let's say, as long as it's standard of care, there's no problem. I told you what my standard of care for GBM is: radiation, chemotherapy of Vitamidar, MRIs every 2 months. Insurance would pay for that. However, once they recur and we do out of the box treatment, which we do all the time as oncologists, then you have problems with commercial insurance. But what we do is we give them the case report or the case study or the randomized controlled trial, which we're basing the treatment on, and you write them a letter. And then, in my experience, once we do that, it usually goes through. So I guess I would say it's not hard, because once you put all that work, it goes through. But again, technically, you should ask, why are we doing this? Are they just supposed to be supporting you with the treatment? Because these are patients with cancer, for crying out loud. So I guess, I guess commercial insurance, there is some pushback about non-conventional treatments. Unfortunately, for me, I can do mostly whatever I want, because I do through patient assistance program with a pharmaceutical company.
Our next question is, as someone who is an international student, how do you feel about introducing this kind of medicine to other places in the world, and particularly places that aren't as fortunate to afford the procedures? Would it be too invasive?
You know what? That is an excellent question. So I'm non-conventional. I did my undergrad in the Philippines. I did my master's medical school residency fellowship here. So I'm from the Philippines. I had never trained medically in the Philippines. And so what happened was, during my last year of residency, I was able to get a 1-month scholarship to go and learn how neurology was practiced in the Philippines. And it was very, very different. They don't even give TPA. So just give you a brief background. If somebody has a stroke, if it's 4.5 hours from the onset, you push a clot busting medication called TPA or Altiplase to dissolve that clot. Works like magic. You basically don't have a lot of residual deficits because you were able to lyse or dissolve that clot. Totally not the practice in the Philippines. Their grand rounds when I was sitting there was to TPA or not to TPA, and I was like, well, that was the question, but then here we give it like candy, as long as the patients reach the criteria. And so my point is, it's very different, because there in the Philippines, I don't think they have a neuro-oncologist. I think the brain cancers are treated by oncologists, you know, and then oncologists have breast cancer to focus on, lung cancer, you know, bladder cancer, skin melanoma, all other types, head and neck cancer. And so do I expect them to attend this neuro-oncology conference and no cutting edge, just neuro-onc brain cancer? I don't. And so I would anticipate that the practice would be very different, very difficult. You have to go through government for funding, like, you know, like let's say the TPA for stroke, not for, because I was there as a neurology. I haven't done a neuro-oncology like study there, a feasibility or a exploratory study, I called it, for neurology. But the TPA that was supposed to be given for stroke there costs about $1,000 to administer. Convert that to pesos. Nobody has that in the Philippines right out of their pocket if they have a stroke, acute stroke. And so I am sure that the same scenario I would meet if I would go there for an exploratory study for neuro-oncology, and I'll be, you know, I will be very interested in the future, and I was planning on it, you know, to maybe do a lecture, and you know, when I go back and try to share my knowledge and to my home country.
All right. Our next question is, what advice do you have for students who plan on applying to both MD and DO schools?
MD and DO schools advice. I think it would be the same as for everybody else. You know, be good at in your undergrad. Make sure that you have a competitive GPA. A post-bac or a master's program will help a lot. Now, regarding the specific question of MD or DO, I think it's a good idea to know to know your programs. Like I said, for neurology, there are DO programs. For MD, there are allopathic programs. I looked at the neurology programs for the DO at that point. That was how many years ago? There were not a whole lot. And every time I open one, there's not a whole lot of residents. And for me, I look at it as, if you don't have a whole lot of residents, that means it's a smaller hospital. So that means that maybe, perhaps, not necessarily, I'm not generalizing, but the possibility that if it's a smaller hospital, your pathology is not going to be as good as in a university or a big hospital, right? And then if you are only 3 residents, imagine that your work-life balance as a resident. So you'll be on call all the time. So I look at that. So, you know, I look at those things when I apply for residency. And so as a neurology applicant, I did that. So that's the decision. That's what made me make the decision to not apply on the osteopathic neurology programs and just do the allopathic. And I did that. So my advice for you is, know what you want. Know what city you want to live in. Know what your priority. For me, a good priority to have is the pathology that you will see. If you would see a whole lot of pathology, you'll be a very good doctor when you come out of the program. Next, work-life balance. How many residents are there? You know, what are the call schedule? You look at that, because you can talk. They sometimes have an email for the residents. You can email them in advance. And you look at those things. And you know, and at the end of the day, you decide: do you apply to the DO program or you apply to the osteopathic program? Because I would have said, you know, apply for a mix of both. A lot of my classmates did, but for me, I did not specifically apply to the DO programs for neurology residency because their programs were smaller compared to the MDs, and so that's the reason why. But does not necessarily equate to every subspecialty or every specialty. No. A lot of DO programs are very good in primary care. So you would have a good family medicine residencies, good internal medicine residencies in DO. And so I want you all to look at that as well. Okay.
So those are all the questions in the chat, but at this time, for like the next couple minutes, if you guys have any questions, please do feel free to type it in the chat or unmute your microphones and ask away. We'll be hanging around for a couple minutes. Thank you so much, Dr. Mantilla, so far for helping us out with everything. Your presentation was wonderful, according to a lot of the students in the chat as well. Yeah, it was lovely having you. We learned a lot tonight. So hopefully if other people have any other questions to ask.
And if you do have questions and if you do want to connect, and feel free to email me. I think Netanya has my email. She can distribute that to everybody. Shoot me an email. It could be about neuro-oncology. It could be about applying to medical school, or once you get done with medical school residency, shoot me an email anytime. I'll be more than happy to help you guys out.
I actually have a question that someone just texted me. She had to leave early. She asked, how did you keep your head up throughout everything that you went through? And how did you keep yourself sane in the sense, because this whole situation could be so overwhelming for an immigrant. So how did you stay strong throughout your journey through navigating the U.S. medical school system?
So very, very good question. So I have good support. My wife now is a very good support of mine. I remembered she printed out a lot of the medical school application fact sheets from the frequently asked questions, and then make it into a binder. And so I basically applied for all of that. First application didn't go through. Obviously, I was sad, and then I just retook the MCAT, and one thing that I realized now that I look back is when I applied it for the second time, I did not necessarily do anything to improve my application, which I probably would tell you now that you guys are still undergoing through the first application. Every time, it's not, it's not an assurance that you're going to get during the first try, and it's okay. The number one in our class went to dermatology, applied to med school 3 times, and she is the number one. She scored a 250 on her USMLE step 1, which is like 90th percentile, 99th percentile. But it took her 3 times to apply to medical school. So I don't know what's her reason. Maybe that post-bac that we're both classmates in post-bac in the master's. Maybe that helped her a lot, but to apply. But each step you have to make your application better. What helped me through that? My support from my family, obviously my wife helped me through that. She was there every step of the way. You just have to know yourself, and you just have to know your goal. Is this something that you really want? And that's something that I really wanted, because I told my wife at the time, if I didn't get through medical school here the 3rd time, I'm gonna go home to the Philippines, and I'm just gonna come back here as an international medical graduate. So you're talking about, you already have plan A, plan B, plan C. If it fails, I have a plan D, plan E, and plan F. And so, if you really want something, then you have to work for it. And you just don't take no as an answer. And so during my 3rd application, if they were gonna tell me no, I'm gonna go to the Philippines and get my medical degree there. And so that would be plan E, plan D, and so don't take no for an answer. There's a whole lot of routes going to become a doctor here in the US. And so it's fine. It would have been okay too if I was an international medical graduate. I have international medical graduates as co-residents, and they are excellent, very good, and it's not bad. It's not a bad thing to be an international medical graduate, not at all. One of my best friends in residency, she graduated from Ross Medical School. And we went through residency together, and she was an excellent resident. And so, it's not, have backup plans, and psych yourself up that it's okay to go through plan A, B, C, and D. Because if you really want something, you wouldn't mind going to plan Z until you reach the goal.
Just to add on to what you were saying, Dr. Mantilla, I was looking up the statistics while you were speaking. In 2019 to 2020, 41% of medical students were accepted, but the record statistic in 2019 was 52%. So that's still like half. So really hard to get into
for medical school.
Yeah, and the ordeal.
Yeah, so and that's the reason why these medical sciences post-bac programs are getting bigger and bigger every year. They started with about 20 students 5 years before I started, and during my class we were 100, and now there are 3 sections. So it's getting bigger, because I think it's getting more competitive to get in. And like I said, try to make your application stand out. I realized that when I was logging in, you guys had this opportunity. Was it like a surgical or something in another country? Those are really good in the application. Those are things that try to make your application stand out. So like I said, make each application better than the last one.
I also wanted to ask, like you said you applied maybe 3 times around, if you don't mind answering, and if you remember, about how many schools did you apply to each cycle? Because it gets really expensive and everything.
It is. I can't remember at the top of my head, but I probably would say I probably applied to more than, maybe let's say 30 schools each application. I do about 30, and then the third time I applied to Texas schools. Texas School has its own application system. It's called TMD SAS. And that's about, at that time, 7-8 schools in itself, in addition to the other schools that I applied for. And then, because for me, I remember I applied for both DOs and MD as well. So you do the I forgot what it is it AACOM, or I applied for both MD, DO, and then the Texas school. So if you add this all up, it will become more than 30 easily. Anything else?
Any last questions before we wrap up for the night?
Feel free to email me, and if you have anything last minute, or you forgot to talk to me about, be it neuro-oncology, neurology, or application to medical school, residency, shoot me an email, okay? Or when we can talk, okay?
If there are no more questions, I think we can end tonight so that everyone can get rest for exams and get ready for Thanksgiving this week. But I just wanted to say thank you again to Dr. Mantilla for taking the time out of your busy schedule to talk to Rutgers University students. It really means a lot to hear from someone who's successful, but whose backstory wasn't as perfect, which is a lot of what we're looking for these days. So we really do appreciate you coming tonight to talk.
No problem, anytime.
Thank you.
You're welcome. Happy Thanksgiving, everybody.
Happy Thanksgiving. Have a good night, everyone.
Bye-bye.
Thank you.